Greetings to our partners from mostly Geneva and Swiss-based organizations, global health players who are committed and supporting this cause of the global sepsis response, as well as the attendees on the live stream. Today's event in Geneva, 5 facts, 5 actions for sepsis, how we can accelerate the global response to sepsis, is part of the 2025 World Sepsis Day campaign that we launched on September 5 with a global webinar for journalists. It continued on September 9 through our patients-led Brussels meeting with engagement of WHO Regional Director and the Minister of Health and Vice Prime Minister of Belgium. On September 11, we had regional meeting of the Eastern Mediterranean Sepsis Alliance, bringing key experts and stakeholders from the Eastern Mediterranean regions in Riyadh. On Friday, September 12, we had the primary press conference, the central press conference on the World Sepsis Day in Berlin in partnership with Virchow Foundation, Unite Parliamentarians Network, Sepsis Stiftung, German Health Alliance, and Swiss Sepsis Program. And today, we're convening this meeting also in partnership with our strategic players, including Health Diplomacy Alliance, Swiss Sepsis Program, Unite, and Virchow Foundation. We are extremely honored and grateful to Dr. Tedros Ghebreyesus, Director General of the World Health Organization, for his unwavering commitment to the Global Sepsis Alliance cause and for sending his special video address for this year's World Sepsis Day campaign as well. We will be soon hear from Dr. Tedros, but today we are especially honored and grateful that Epifanio family, parents of Elia Epifanio, the photo of Epifanio you can see on the banner, the main banner of our event, are here. After the tragic loss of Elia 2 years ago in Zurich, Jennifer and Danielle became the strongest voice in Switzerland for raising awareness. What happened to Elia should not happen to any child and any family. And we are speaking about Switzerland with one of the best health services and the best accessibility to the quality of care. Jennifer, Danielle, thank you so much for coming from Zurich today specifically to join our meeting, and hope that this event will be a new chapter for mobilizing our global health players and reaching out to the decision makers for prioritizing sepsis where it needs to be. Thank you. Without much ado, let us hear from Dr. Tedros Ghebreyesus, WHO Director General, and the great supporter of the Global Sepsis cause.
Dr. Mariam, Jashi, Dr. Tex Kissoon, dear colleagues and friends, there are almost 50 million cases of sepsis globally every year, half of which occur in babies and children, primarily in healthcare facilities. Most of the 11 million deaths caused by sepsis every year are preventable through low-cost infection prevention and control measures, early diagnosis, and rapid treatment. WHO is working with countries and communities to strengthen health systems to reduce the impact of sepsis. We have guidelines on reducing bloodstream infections, and we will soon publish guidelines on the prevention and clinical management of sepsis. We're also studying research priorities for maternal sepsis and how to reduce antimicrobial resistance, which undermines our most powerful tools to combat sepsis. Through WHO's Acute Care Action Network, we're working with 80 partner organizations to implement tools shown to dramatically reduce the deadly impact of sepsis. I thank the Global Sepsis Alliance for your leadership and partnership, and all of you for your commitment to preventing and treating sepsis. Because nobody should die while seeking care. I thank you.
Our sincere gratitude to Dr. Tedros, and we hope that very soon sepsis will be positioned higher in the global health architecture where it deserves to be, because the cause taking every fifth life cannot be this invisible in the global political arena and the global health dialogue. I'm also immensely grateful that even though Dr. Yukiko Nakatani, who is the Assistant Director General of WHO, has delegated her representation to Dr. Yvan Hutin, the Director of the AMR Department at WHO. Dr. Hutin, thank you.
Good afternoon. I'm very grateful for the invitation, and on behalf of Dr. Yukiko Nagatani, who is Assistant Director General for Health System at WHO, we would like to provide all our support for this day and event. So Dr. Yukiko Nagatani, now following the reorganization of WHO, is leading a division that really addresses all the health system building block, which hopefully will continue to further strengthen every health system in the world so that we can respond to health threats, including sepsis and including AMR. And the AMR department, now located in this division, is a pledge for WHO to really address AMR and sepsis through a health system strengthening sort of a way. So we fully support your work. We hope that we can continue to work together so that we can educate people on the early management of sepsis in the broader context also on making sure that we can have access to all the diagnostic and antibiotics that are needed in the health system, and making sure also that we have the right trade-off between raising awareness regarding the severity of sepsis and also the overuse of antibiotics. We're also very happy to see your call for action in terms of the management for sepsis, and it's really something that in the context of this new division for health system, WHO will continue to organize in the broader context of PHC-oriented health system, which organize a whole system of referral to care so that people can be managed, diagnosed, and managed early. Thank you so much, and over to you.
Dear Hutin, thank you very much for your opening remarks. And we fully agree that the only way for prioritizing sepsis is through integrated approach, integrating sepsis prevention and clinical management into the primary health care and universal health coverage programs is the way forward, because sepsis, due to its critical linkages starting from immunization to water and sanitation, early detection, antibiotic, immunomodulatory or post-sepsis care and rehabilitation can be one of the best proxy indicators how well health systems work. We look forward indeed to closer collaboration with the new division after the restructuring and reforming process of WHO, and look forward to synergizing better, especially AMR and sepsis-related policies and messages. Let me now hand over to the founding father of the Global Sepsis Alliance, the person who has been behind of establishing the World Sepsis Day movement, World Sepsis Congresses, and the WHA sepsis resolution in 2017, Professor Konrad Reinhart. Konrad, the floor is yours.
Your kind words, and indeed WH Director General is right. Sepsis is one, if not the main cause of preventable deaths worldwide. And there are new figures from our colleagues from the Institute of Health Evaluation and Metrics. And it was already demonstrated over the last 140 years now that it is preventable by vaccination, clean care, early recognition management as an emergency. And if you see this decline, which started with 800 deaths per 100 population who died from sepsis, only interrupted in 1919 by the so-called Spanish flu. And it went on, and the measure have been better sanitation, chlorination of water, development of vaccines, development of antimicrobials. And the nadir was in 1984, there were only 36 deaths per 100,000 population. However, as we know now, even in high-income countries, it can be as high as 250 deaths per 100,000 population. And globally, and this is now also available as a preprint, not yet peer-reviewed, again by the authors of the Global Burden of Disease report, they came up with estimates of 21.3 million deaths and 160 million cases. Notably, these were in the COVID-19 times. And we know in the meanwhile that about 1/3 or 1/4 of deaths caused globally and in the individual countries by viral sepsis due to COVID-19. Sepsis can hit everybody. Famous, not so famous, children, elderly. However, those who are most prone to sepsis are those in the LIMC. In sub-Saharan Africa, and this data is by courtesy of Dr. Moschen from the EIHMA, who was not able, because he's traveling, to be here and present, and he provided me some of his slides. You see that mortality again in 21, 405,70 deaths globally. This means not only 20%, but more than 30% of all global deaths are attributable to sepsis, despite a decrease of 50% over the last 30 years, which again explains the preventability. And in some, and this are the red colored, deeply red countries, this means that up to 77% of deaths in these countries are attributable to sepsis. And overall, the deaths, back please. The deaths decreased until 2019, but then increased again with an overall yield of 55 million deaths in 21. And interestingly, and not surprisingly, of course, the leading 6 non-infectious causes or underlying causes of sepsis occurred in patients with stroke, chronic obstructive pulmonary disease, COPD, cirrhosis, ischemic heart disease, neonatal encephalopathy, and colon and rectum cancer. And this is again data from Dr. Nachavi, who reports in LIMCs the dramatic improvement, and now we are talking on countries where the mortality rate was over 1,000 per 100 population, which dramatically declined over the last 30 years. And it raises the questions how it came that this was not on the agenda of departments of health in various countries, but also only as maternal and childhood sepsis by the authors of WHO and also EIHMA at the Global Burden of Disease report. So it's possible, and this is Philippines, Mongolia, Colombia, Brazil, Ethiopia, etc. There are still a lot of differences. Next, please. And this is high-income countries. And what you see here is indeed the increase by deaths during the COVID-19 pandemic, which was much more dramatic than in the low-income countries due to the fact that we have aging populations with a number of concomitant diseases. And there are countries like United Kingdoms where it's were 300 deaths per 100 population. In Germany, it were 250 deaths per 100 population. But there are other countries like Australia who had only 110 deaths. And this again explains us the potential that enormous potential to reduce not only mortality and the suffering from families, but also we calculated alone the costs for Germany. And it's 11 million for acute care, and it's over 20 billion for sepsis sequelae. Next, please. And this is a summary in some way by Dr. Moschen. And you see again the figures that globally there was a decrease from 60 million deaths from 1990 to 14.1 million deaths, which then increased, as discussed in the overall globally during the COVID-19 pandemic. And if you look on the high income deaths, they even increased until 2019 and then again increased by COVID-19. And in LIMC, the progress that has been made, the decrease from 50 million to 12.3 million. So this can be summarized that it's an issue for both high and low income countries. And interestingly, this ranking, which we published in a major journal in Germany, how badly Germany is doing in comparison to Norway, to Australia, to Switzerland, and to Denmark, tells us that it's the quality of a healthcare system. It's not about resources. It's about a healthcare system is organized in terms of prevention, education, which needs to start in the schools, etc. And sadly, for my country, in Germany, during these 30 years, nothing changed, despite our own efforts with quality improvement efforts. And in detail, and this is mostly a comparison to Switzerland, the risk of newborn of dying in Germany is twice as high in Norway. For newborns, the risk of dying is also pretty high in the Switzerland. But the chance that you die or risk of dying when you have major abdominal surgery is almost twice as high in Switzerland as in Germany. The risk of deaths is fell over the last 30 years, but only 10% in Germany and 44% in compared to 44% in Switzerland. And the risk of dying from an urinary tract infection in Germany is almost 30% higher than in Switzerland. So why? It's just education and priorities, next please, of the healthcare systems. And just to reiterate, and this is my last slide, Germany is doing quite well in the number of excess deaths during the pandemic. Why is it? Because during COVID-19, the whole society, media, policymakers on the federal and the national level communicated, they did not communicate that the cause of death is sepsis, which is an extra issue, but it underpins the strength of countries like Australia, who have also a low mortality from sepsis by other causes. They have a negative scores, which means they had less deaths, excess deaths, and this is data from WHO, which you might publish in Nature. Norway, no. Finland, 2.5. Germany, 6.5. Even better, somewhat better than Sweden, who have half as high a percentage of death from sepsis from other causes, and look at UK, US, Russia, Mexico, etc. So that tells us what, and as courtesy to what Jeremy, not Hunt, but Farrar has said, that really sepsis is a microcosmos for the quality of a healthcare system, and it's not a question of resources. Thank you so much for your attention.
Thank you, Konrad, and thank you for all your leadership of uniting 122 member organizations of the Global Sepsis Alliance, establishing 6 regional sepsis alliances over the last 13 years, and I'm extremely grateful and honored to be taking over the leadership of the Global Sepsis Alliance from you. Dear colleagues and partners, today's event, as in the case of Berlin and the upcoming New York UN General Assembly side event on sepsis, is live streamed. And as an example, last Friday's event in Berlin was viewed by 1,700 colleagues and stakeholders. So the messages, the discussion that we will have today will have an amplified effect across the regions and our partner organizations worldwide. We have 3 video messages from the leaders of the Global Sepsis Alliance and our key strategic partner agencies. And let me present to you Professor Niranjan Kissoon, the president of the Global Sepsis Alliance, who is the professor of the British Columbia University and Child Hospital. He is one of the brightest minds in pediatric sepsis, especially in low and middle income country contexts. So it's a pleasure to present the video address from Tex.
Ladies and gentlemen, colleagues and friends around the world. Today, on World Sepsis Day 2025, we unite across borders and time zones and languages with a shared mission to raise awareness and to save lives and advocate for strong action against sepsis. Sepsis is a global health threat hiding in plain sight. It is the #1 killer in the world and the leading cause of death that mostly affects those who are vulnerable in most societies, but also can affect anyone regardless of age, income, or geography. Yet it remains poorly unrecognized. Every year, over 1 million lives are lost from sepsis. That is, 1 person is lost every 2.8 seconds. Many of these deaths are preventable with simple measures, and many survivors suffer long-term consequences. Sepsis is also treatable if with timely recognition, timely treatment, and robust prevention strategies. We are not powerless. We need to act together to decrease the burden and improve outcome in sepsis. In recent years, many hospitals has made progress by adopting sepsis protocols. Some governments have developed national action plans, starting to track and report sepsis data. Survivors are bravely sharing their stories, and healthcare workers are being trained to spot the signs of sepsis earlier. This is all in the right direction, but a stronger and more concerted effort globally is needed. This year's theme reminds us that awareness leads to action. Whether you're a policymaker, a healthcare professional, a patient advocate, or simply someone who wants to make a difference, your voice matters. Every poster shared, every story is told, every policy change can ripple outward and save lives. On this World Sepsis Day, let us commit to the following: educating our community so that everyone knows the early signs and symptoms of sepsis and the way to seek proper health care, equipping a healthcare system with the tools, training, personnel, and equipment such that they can respond quickly to sepsis, empowering survivors and families to speak up and advocate for change, and ensuring that no one anywhere dies from sepsis because of lack of knowledge or delayed care. Let us remember that behind every statistic is a name, a face, a loved one, a family member, members of our community. Sepsis may be silent, but today we need to speak loudly. Together, we can turn awareness into action and action into impact. So therefore, I would like to congratulate you on your efforts on this World Sepsis Day, but let us be the start and not the end of our efforts. We need to be very much cognizant that sepsis in some parts of the world are increasing, and with our concerted effort, we can make a difference. So on behalf of the Global Sepsis Alliance, I'd like to thank you very much for all that you are doing.
Our next video address is from Professor Evangelos Giamarellos Bourboulis, who is one of the widely published authors, researchers, the scholars in clinical management of sepsis. He is the chair of the European Sepsis Alliance, who is extremely vocal at the EU policy advocacy level, and the widely kind of awarded also researcher from AskMed and other prestigious platforms.
Good day. My name is Evangelos Giamarellos Bourboulis, and I'm the current chairman of the European Sepsis Alliance. Today, I would like to share with you the views, not just of myself, but also of all the steering committee of the European Sepsis Alliance regarding our urgent call to improve sepsis care in Europe. This is my conflict of interest disclosure for this presentation, and I would like to share with you some numerical and statistical data, which I'm certain that you're probably aware of. In 2016, the criteria for the definition of sepsis were settled in a very robust way, which allowed for the entire 2017 to calculate the total number of sepsis cases around the globe. Here you see in the global map the cases of sepsis for each of the 5 continents, and each color represents a different incidence. In other terms, this map presents the new cases of sepsis every year in the world, showing that almost 50 million people present every new year. And I would like to focus your attention to the lower confidence interval, which is by definition at least 4 million new cases. And from all these patients, 11 million die every year, which is far more than the total number of deaths happening during all the years of the pandemic. When the new steering committee of the European Sepsis Alliance came in power, it was decided that what is really needed was to know the map of sepsis care in Europe. After a lot of exchange of thoughts and under the leadership of Professor Konrad Reinhart, it was decided to run a multidisciplinary cross-sectional analysis of structure and capabilities of sepsis care in hospitals in Europe and also in other parts of the world. In other terms, what we know, the general public, in the emergency department, in the ward, in the intensive care unit, and also regarding quality control, regarding the capabilities on early recognition and screening of sepsis, application of guidelines and protocols, diagnostic modalities, and also quality indicators. Each and every one healthcare professional in a vast majority of hospitals around Europe, but also outside Europe, received an online questionnaire, and that was approved not just by us, but also in collaboration with all major European societies. And the idea was to provide that questionnaire in different languages in order even for the non-experts to be able to complete the question. This is a regional distribution of the participation of the number of hospitals. You see that the vast majority of hospitals are coming from Europe, but also we have representations from other parts of the globe. And our first question was, what is the ability of screening for sepsis per hospital around the globe? What we did was to separately ask for that question in healthcare professionals working at the emergency department, in the general ward, in the intensive care unit, and then we split the questions according to the geographic distribution, probably driven by the conviction that the level of the knowledge would be perhaps similar in some parts of the Western world compared to other parts of it. The gold standard of care is the dashed green bar, which you see on top of each bundle. And much to our surprise, none place in the world, none location in the hospital is managing to perform at that standard. All of them, they perform below that in terms of screening. But when the question changed into providing sepsis management, what you get is exactly the same. And then the real question is, why that? Because as a matter of fact, the administration of the hospitals is not really aware of sepsis, and there are no quality control measures which are implemented around the world to see if indeed what is needed to save patients is taking place. So our teachings, which we reviewed as a steering committee of the European Sepsis Alliance in a recent publication of intensive care medicine, was that 33 to 55% of the units have no standardized screening, 23 to 61 have no SOPs for management of sepsis, 70% of the hospitals have no training or quality improvement program, and almost 90% of the labs have limited service, which causes delays. So we suggest that it is essential to implement basic measures and structures in different countries, and audits are needed to make certain and to quantitate that these are implemented. And as a matter of fact, it's not that difficult to save a patient. What is needed is just a simple action which needs to take place immediately upon early sepsis recognition. And what means early sepsis recognition? Here is a simple example. A patient with drop of blood pressure, but also with signs of infection. And what you see is that if you manage at the level of the emergency department to start antibiotics intravenously within 1 hour of arrival at the emergency department, his 28-day survival will be 80%. And for every hour of delay, there is a relative decrease of survival by 7.6%. And it's so easy to be implemented, but the healthcare provider needs to be trained about that, and auditing should be in place for this. And as a matter of fact, we are at a relatively good coincidence, because after the pandemic, we had major teachings. Teaching learnings us that all patients, although may appear similar in terms of their clinical signs, in the ICU. They differ greatly. That's exactly all these 3 patients who are intubated, but they have different comorbidities. They have different lab values. They have different C-reactive protein and different ferritin. This allowed us during the pandemic to learn that not all patients behave the same, and they are under a different mechanism. And if you manage to identify a biomarker, as in our case, the biomarker is named SUPAR, which if it's increased, you drive very early immunomodulatory treatment. The immunomodulatory treatment in our cases is anakinra. And with that approach, you manage to improve outcome by day 28 by a relative 64%. And this indication was approved by the EMA. It was approved by the FDA that with just a biomarker, you may know who's the patient who will get most of benefit by immunomodulatory treatment. And that later on led us to use 2 different biomarkers, ferritin, to judge and to classify a patient as need of receive or intravenous treatment with anakinra, or HLA-DR, which means that the patient, if there is a drop of HLA-DR, suffers from immunoparalysis, to start subcutaneous treatment with recombinant interferon gamma. But in order to reach so, no one coming from the industry could help us because both drugs, they're considered off patent. With that in mind, we addressed to Horizon 2020. We managed to receive a grant, and with that grant, we randomized patients with sepsis into precision treatment with either anakinra or recombinant interferon gamma or matched placebo with an endpoint, which is the mean SOFA score. But here is where we need action by the regulatory and also by the EU level. Because if this turns out to be positive, it is obvious that, again, the industry will not be interested for 2 off-patent drugs, but the EU should be interested to save lives. In other terms, the continuation of this towards a phase 3 program needs to be supported by the EU. And it's not the vision of the one who's talking to you today. It is the vision of colleagues from Germany, from, of course, my country, from Italy, from the Netherlands, from Romania, and from Switzerland. And allow me also to give you a different example. Vilobelimab, a monoclonal which targets C5a and which was administered during COVID-19 in critically ill patients under mechanical ventilation, showing decrease of mortality and giving FDA emergency use authorization. This is another example of the responsibilities of the EU to encourage to move these drugs to the scenic of sepsis. With that in mind, it is obvious that all healthcare professionals need to receive better training in order to recognize early signs of sepsis and initiate timely treatment. Sepsis should be explicitly stated in discharge documents of the patients. Sepsis should be registered and documented accurately in patient records and not to be considered as a secondary complication. Clinical pathways for sepsis should be developed that spans the patient journey. And also, national public health campaign should inform the general public about sepsis, as 80% of cases develop outside the hospital. Educational packages on infection prevention, health hygiene, and early warning signs should be offered. National governments should ensure universal access to sepsis management and affordability of sepsis care and rehabilitation. And the European authorities and national governments should invest in sepsis research for generating reliable epidemiological and clinical data, as well as to foster new therapies. With that in mind, I would like to thank all members of the steering committee of the European Sepsis Alliance, which also framed part of the European Sepsis Care Survey Steering Committee. I would like to thank the members of the European Sepsis Care Steering Committee, which are not members of the steering committee of the European Sepsis Alliance, but most, I would like to thank our daily heroes, which are our patients and their relatives. Thank you so much.
Professor Giamarellos Bourboulis highlighted in his slides that last year, the European Sepsis Forum published a Paris Declaration in Lancet as the call for action to the EU Parliament and EU authorities to develop the regional sepsis plan. And as mentioned, our true warriors are the patients and families, and our call to action continues. Last year, we had the European Sepsis Alliance meeting at the EU Parliament, and we will continue our advocacy and the call for action. And our last video address is from our dear friend and colleague, Dr. Ricardo Baptista Leite, the president of the United Parliamentarians Network for Global Health. Ricardo again will be joining us in New York on September 24th.
Hello, my name is Ricardo Baptista Leite. Hello, my name is Ricardo Baptista Leite, and I am the founder and president of the Unite Parliamentarians Network for Global Health, a network of more than 500 legislators from 120 countries working together to promote science-based policymaking in the field of health for everyone, everywhere. I am deeply honored to join you today on this World Sepsis Day, and I want to apologize to all of you, and in particular to my dear friend, the president of the Global Sepsis Alliance, Mariam Jashi, also a longtime supporter and member of the board at Unite. I apologize for not being with you. However, I couldn't let this day pass without sending a very strong message of support, because today we see that sepsis is part of the political agenda. And this was something that was not a reality not too long ago. Things are changing. And that's also because of the amazing work in terms of raising awareness, of promoting policy change that the Global Sepsis Alliance has been spearheading, along with patient advocates, with sepsis survivors, with communities around the world. And I want to acknowledge that and to say that you can continue to count on our support on this journey. We know that sepsis represents a tremendous burden in people's lives and their caregivers, on health systems, and in societies in general. We're talking about 11 million deaths per year that are attributable to sepsis alone. We know that in terms of costs, we're talking about 62 billion US dollars, which are spent annually on sepsis healthcare costs in the United States alone. And of course, as in most cases when it comes to health, it is those that live in most vulnerable conditions are the ones that are hit the hardest. People who live in low and middle income countries, children under the age of 5, the elderly, people who live with immunocompromised conditions. So we need to call to action everyone to make sure that countries prioritize their response to address sepsis, to develop sepsis control protocols, to train healthcare professionals, and contribute to people's literacy on the matter. Parliamentarians have a very important role to play. Members of parliament, of course, are the ones that keep governments accountable, are the ones that approve budgets, get budgets through the parliament. They are the ones that promote and change policies. And most importantly, parliamentarians in democratic societies are directly elected by the people and represent directly the people. And so we need the voice of the people in this movement. And so members of parliament must be aware of the true impact that sepsis can have on their nations, on their citizens, and assume a crucial role in advocating for prevention, early detection, and timely and effective treatment. We need parliamentarians to use every tool at their disposal, be it in terms of legislation or budgetary tools, or simply the power they have when using the media to advocate for the creation of national action plans for sepsis. We need, of course, to increase funding in terms of response to sepsis, but also in terms of research and development, so that we are able to avoid sepsis in the future. And until we reach that point, that new antibiotics can actually be developed along with other treatments, because as we know, with the rise of antimicrobial resistance, we may reach a point where we do not have treatments, as we already are seeing in many parts of the world, that are effective in treating severe infection and lead to sepsis. We need to develop better diagnostic measures to ensure timely response and ensure that proper infrastructure and resources exist within national healthcare systems to address sepsis. And therefore, sepsis also needs to be prioritized by those leading health systems across the globe. Finally, at Unite, as I said, representing current and former parliamentarians from 120 countries around the world, we are committed to promoting these messages, but most importantly, on calling parliamentarians to take these actions so that along with the Global Sepsis Alliance, we can continue to progress in the direction that we've been seeing, which is not only making people aware about sepsis, but actually doing something about it. And so, my dear friend Mariam Jashi, my dear friends at the Global Sepsis Alliance, and everyone in the fight, I want you to count on the Unite Parliamentarians Network for Global Health. We are together to raise awareness, to make sure that everyone does their part so that we can fulfill the 2030 Global Agenda for Sepsis. Thank you.
I'm extremely grateful to Ricardo as a true global health leader and champion. And with the support of over 500 legislators, former and current parliamentarians across 110 countries, we hope that every year we will make more and more difference. We will speak in the houses of parliaments, the houses of people, and turn the global sepsis response truly into the next success story and next chapter of the global health. Now, I believe we have the most important speech for today. I would like to invite Jennifer Epifanio, mother of Elia Epifanio, and again, Elia's picture will remain on the banner. He is the face of sepsis, and having known this family, having met this family in person, it has been a true honor, and we're extremely grateful that after all you have gone through, Jennifer, Daniel, you're now helping us to protect others and save others. So please, you can choose where.
Good afternoon. My name is Jennifer Epifanio. I'm the mother of 3 sons and the founder of the charity kart race Trofeo Elia Epifanio. I'm here today to share the story of our eldest son Elia, whom we lost to sepsis at the age of 14. I share his story today because I want to prevent other families from experiencing the same fate that we did. Elia was healthy, athletic, and full of energy. He was one of the greatest karting talents in Switzerland and had his whole life ahead of him. He returned from his school ski camp on the first day. The next day I took him to Italy to train for the upcoming Swiss karting championship. That day he only had a slight cough. By Saturday he showed mild cold symptoms, but still wanted to visit the newly opened karting track in Wohlen. I remember how excited he was and how much he was looking forward to driving his first laps. But sadly, that never happened. Since he had celebrated his 14th birthday during ski camp, we held his birthday party with family on Sunday. Looking at the photos from that day, one would never imagine that less than 24 hours later our son would be fighting for his life. That night, from Sunday to Monday, Elia developed a high fever, severe cough, very noticeable breathing problems, and strong pain. It was so bad that my 14-year-old son lay crying on the floor, begging me to take him to a doctor. Since neither his pediatrician nor my own doctor had an appointment available, Elia insisted that I take him to the nearest hospital. By the time we arrived at the hospital around midday, was so severe that he could no longer walk or speak on his own. I had to bring him to the pediatric ward in a wheelchair. After 4 hours, the senior physician told me that my son had influenza B and that we should go home and only return if things got worse. In front of the doctors, I placed my very sick son, who could no longer walk without pain and was struggling to breathe, back into the wheelchair and took him home around 5 p.m. That same evening, Elia began coughing up blood. An ambulance rushed him back to the same hospital, to the pediatric emergency unit. My husband and I stood there, not knowing what was wrong with our child. Suddenly, panic broke out, and Elia was transferred to the shock room in the general emergency ward. He was fully conscious and angrily asked, "How much longer will this take? When can I finally go home?" My husband tried to calm him and say, "Elia, everything will be okay. Are you afraid?" Our son's last words in his life were, "Yes, Dad, I'm afraid." Elia was then transported by ambulance to the University Children's Hospital in Zurich. When he was carried out of the ambulance, it was the last time I saw my son half conscious. He was taken directly to the shock room and had to be resuscitated multiple times. At that point, we still did not know what was wrong with him. We were taken to a waiting room while our child's life hung in the balance. A doctor finally came and for the first time used the word sepsis, a term that was completely unknown to us. At that moment, the meaning didn't matter. The only thing that mattered was that our son was still alive. Doctors explained that Elia's condition was so critical that he could only survive if he was connected to an ECMO machine which takes over the functions of the heart and the lungs. After this procedure, we were allowed to see him again before he was transferred. When I saw my child intubated, attached to 20 different IV lines with dark patches all over his body, it became clear to me, no matter how we would leave this hospital, life would never be the same as we were entered. The only question was, how bad would it be? He was then admitted to intensive care unit B, reserved only for the sickest children. The next day, Tuesday, we were told that Elia was the sickest child in all of Switzerland at that moment. I still remember looking at the doctor in disbelief thinking, what are you telling me? My child, the sickest in Switzerland? Just 4 days ago, I was with him in Italy, training for the championship. How could this be possible? I secretly hoped it was all a huge mistake. Doctors mentioned a survival chance of about 50%. It was probably never that high. All we could do was hope and pray. It was agonizing, watching your child so gravely ill and knowing that there's nothing you can do to change it. The following day, new information came. Doctors considered amputating his legs to stop the sepsis, but with no guarantees that the brain damage from resuscitation could be avoided. But in order for the surgery to even be possible, Elia's condition would have needed to improve within 24 hours, and it didn't. On March 31st, 2023, the very day Elia was supposed to compete in Italy for the Swiss Karting Championship title, our son died of septic shock in the hospital. Before losing our son, we had never even heard of sepsis. Like many others, the term was completely unfamiliar to us. That is why, in memory of our son, we founded the Trofeo Elia Epifanio charity kart race in 2024. The race was built on 3 main pillars: to keep Elia's memory alive, to raise awareness of sepsis and reach as many people as possible, and to collect donations for the University Children's Hospital in Zurich. I'm here today because it is vitally important that we speak more about sepsis in our families, among friends, and also with healthcare professionals. Most importantly, we as lay people need to know the symptoms of sepsis and respond quickly if necessary, because that can save lives. Everyone should know the key symptoms of sepsis, especially in the case of flu or another infection. In Elia's case, the symptoms were abnormal breathing, mottled skin, and a lethargic apathetic state. I share our son's story publicly so that sepsis becomes better known, so that symptoms are recognized early, so that other children and families get the chances in life that were taken from us and from Elia. And so that we take responsibility together, as a society, as families, as friends. Thank you for your attention.
It's extremely difficult to speak after you, Jennifer, but thank you for making this speech so bearable for us in terms of listening, because you tried to focus not only about the facts and the flow, how Elia's case developed, but what we need to do to protect others. Thank you immensely for being with us today. Thank you for all what you're doing in Zurich. I was impressed by the work that you are doing with the charity race and all the funds mobilized through the charity race. Trofeo Elia Epifanio are channeled to the Zurich Children's Hospital to save other kids. This is an amazing family. I'm sure Elia is really very proud of what you are doing. And we have also another promise. We have to make the Trofeo Elia Epifanio much more known globally. And you are already doing a lot on that, but we will also help, we promise. Thank you again. It's a very difficult transition after hearing from Jennifer to the presentation that I'll have to deliver today on the 5 facts and 5 actions about sepsis. But again, Elia is the face behind every sepsis case. Each of the 11 million deaths that sepsis causes every year. During the last years, Global Sepsis Alliance was convening multiple scientific events about sepsis during the World Sepsis Day. But this time, we want to focus more on media awareness, policymakers' awareness, not necessarily experts' awareness, because they already know the importance of sepsis. So with the current campaign, we would like to simplify the messages around sepsis and call for action. And before we move to the 5 facts, 5 figures, let me once again reiterate that the 2030 Global Agenda for Sepsis, the very first multi-year strategic document that calls for making sepsis the next success story in global health. This was developed in partnership with more than 70 stakeholders globally, 6 regional sepsis alliances, and Virchow Foundation, Unite, Clinton Health Access Initiative, the Global Antibiotic Research and Development Partnership, and the technical support from the staff of WHO in Geneva and other regional offices. We were honored to launch this first strategy at the German Parliament last year in partnership with the Global Health Subcommittee of German Bundestag, Virchow Foundation, Unite Parliamentarians Network, and Sepsis Stiftung. This document is built on the 5 strategic pillars, how we can make sepsis the next big chapter in global health, because it must be more visible, more spoken about. And again, we had the special honor of having a special video address for the launch of the 2030 Agenda for Sepsis from Dr. Tedros, and this was also highlighted on the website of the World Health Organization. So building on this strategy, we wanted to give 5 major facts and 5 major actions, what each of us can do against sepsis. Fact number 1, sepsis is the leading cause of death globally. Every 3 seconds, someone dies from sepsis. Every year, nearly 50 million children, women, and men are affected by sepsis. Sepsis is responsible for 1 in 5 deaths, 20% of deaths caused by sepsis. And we don't speak about sepsis in every day, in every political show, in every media talk, or the global health dialogue. WHO recognizes the figures from Institute of Health Metrics and Evaluations that at least 11 million people die every year. But the latest estimates from IHME and the University of Oxford are almost double. 21 million deaths in 2021, yes, during COVID period, but still we will discuss these figures later. And again, behind every number, we have a human face. And this is an example from South Africa. Robin Heyer, our friend and the global health expert from South Africa, she lost her father to sepsis. And last year, she sent a message to the Global Sepsis Alliance how she could be part of the global fight. And now she's the member of the Global Sepsis Survivor and Family Committee and helping us to raise awareness. Fact number 2. Globally, sepsis hits the most vulnerable the hardest. 85% of the global sepsis burden is in low and middle income countries, primarily Africa, Asia, and Latin America. But even in high income countries, sepsis is a leading cause of hospital-related deaths. Only in the United States, every year, at least 350,000 people die in hospitals due to sepsis. Higher risks are newborns, under 5 children, women, maternal sepsis. Elderly and immunocompromised people are subject to higher risks of morbidity and mortality, and poverty and limited access to health care directly increases the risks of morbidity, disability, and death. Another phase of sepsis, this is a story of hope. Our colleague, Halima, from Nigeria, her daughter survived sepsis in Africa, and she's currently the vice president of the African Sepsis Alliance. Fact number 3, most deaths are preventable. Every vaccine, existing vaccines, and potentially the new and underused vaccines, they can save millions of lives. Vaccines, water and sanitation, and infection control measures are essential in preventing most of the sepsis cases. But early detection of sepsis is vital, as already spoken by Professor Reinhart and Professor Evangelos. Because every hour of delay in antimicrobial antibiotic treatment increases the risk of death from 0.4% to as high as 7% based on different studies. And sepsis bundles administration of timely diagnosis and administration of intravenous fluids, intravenous antimicrobials, and monitoring of the vital signs. They save millions of lives. And this is an example from the UK Sepsis Trust, one of the best countries in responding to sepsis, despite existing challenges, of course. No country has solved the sepsis challenge as of today, but UK is one of the best in terms of quality of care and awareness raises. Fact number 4, only 15 countries out of 194 WHO member states have prioritized sepsis, either by national action plans or national or subnational policies for sepsis. And this is a paradox. The cause taking 20% of lives and only 15 countries prioritizing. Less than 10% of countries have in place the protocols and guidelines for pediatric and adult sepsis management. And while we applaud 180 countries who have developed antimicrobial resistance national action plans, this is a fantastic achievement. Please remember that sepsis is the human face of AMR, and we have to synergize AMR and sepsis work, and that is why I'm extremely grateful that Yvan today is with us as the new director of the AMR department at WHO. And it's a huge economic cost. 36,000 euro per patient is the direct medical cost from sepsis. And yet we know from Australia, Canada, and New York State in US that it's a greatest, one of the best investment cases with very high return on investment. And those are the countries that have either national action plans or policies in place. Another paradox. Most of the burden is in low and middle income countries. Most of the action policy and evidence generation we see in high income settings. Before we're moving to the fact number 5, let me reiterate the critical link between AMR and sepsis. The 4.71 million deaths to AMR. This is the latest estimates from the IHME and University of Oxford. 4.71 million deaths from AMR associated or directly attributable 1.14 million. They are part of the estimated 21 million deaths to sepsis as direct or intermediate cause of mortality. So how can we speak about AMR and not mention sepsis? How we can have this dichotomy of action? We have to synergize. We have to reinvigorate the integrated approach. And fact number 5, stronger sepsis response is essential for global health. We will not be able to achieve sustainable development goals for maternal, newborn mortality reduction or non-communicable diseases, because sepsis is one of the most powerful proxy indicators how health systems work, from primary care to emergencies, ICU, and post-sepsis care and rehabilitation. And once again, we have the words of Jeremy Ferrar from this year's World Sepsis Congress when he said, sepsis is the microcosm of how well health systems work in integrated way. And that's exactly what we need to promote. Actions, what we can do about those 5 facts. First of all, we need every country to prioritize sepsis. And this is an example from United States, our dearest friends, another amazing family who after the tragedy, after the loss of Rory Stein, became the biggest advocates of sepsis in the United States. And they submitted sepsis bill to the US Senate. Yes, we need health ministers and parliamentary chairs of health to prioritize and invest in national sepsis response. Sepsis should be integrated in health reforms and universal health coverage programs. We are not calling for standalone national action plans. It should be integral into the national health response. And government should seek support to fund the responses, not only through domestic budgetary allocations, but bilateral, multilateral, global public-private partnerships and international financial institutions. Action 2, every country should develop sepsis protocols and train healthcare providers across all levels of healthcare, primary, emergency, ICUs. We need health authorities and professional associations to work together for clinical and community bundles. And we also need sepsis in medical and nursing education. Another excellent example from the United States, the Sepsis Alliance Institute, that's a major national platform that has already trained 55,000 healthcare providers in the United States. Action 3, global health actors should prioritize and fund sepsis response. And this is a historic photo of Dr. Tedros with our amazing sepsis survivors from Sweden and Belgium. Shahrazad and Krista, they participated last year in the Walk the Talk marathon. Sepsis is one of the best investment cases in global health, and each of our stakeholders should be aware and supportive of this message. And that is why I'm extremely grateful that Krista Ben is with us today, one of the leading kind of thought leaders in the global health investments. United Nations should call the governments and stakeholders to invest in sepsis response and sepsis science. We need funding for health sector grants and loans that can integrate sepsis response, either from the World Bank or the regional development grants. Gavi, Global Fund, all of those major platforms provide health system strengthening and UHC windows of funding, and sepsis should be part of those opportunities. And research and development investments for prevention, diagnostics, treatment, and care of sepsis. Action number 4. Media can play a leading role in saving lives from sepsis, and we're extremely grateful to the famous actor and filmmaker Bill Pullman, who is the AMR ambassador. And after meeting us at the Vatican's event, he immediately understood the critical link between AMR and sepsis, and now he's finalizing his documentary on AMR and sepsis that will be released by end of the year. And he visited us in Germany and had a fantastic media coverage of his visit, of course. And then he went to Uganda, UK, and other countries to explore those connections. Sepsis kills more people than heart attacks and stroke, and yet we don't know about it. The public doesn't know about it. And media can be a game changer for raising awareness that this is a time-critical condition, that it requires immediate healthcare seeking behavior. And UK is another, again, the great example. The public awareness on sepsis is over 90% in UK. And US just reached 75% of awareness in sepsis based on their latest studies. Media can help us to hold governments accountable, of course, and to regularly report, not only when the tragedy hits, not only when something terrible happens, but every day reminding that every 3 seconds we are losing a life. And finally, as Evangelos mentioned, 78% of ICU patients during COVID-19 pandemic had sepsis. And every future pandemic will increase the risk of sepsis. And emergencies, humanitarian crises, armed conflicts, they all increase and face the civilians, military, healthcare workers, and humanitarian actors to increased risks of sepsis. So we need sepsis to be integral to the pandemic and emergency plans. Let me conclude with the words of Dr. Tedros, that nobody should die from sepsis, because almost every case of sepsis is preventable if we identify it timely. And finally, we thank our supporters of the World Sepsis movement that currently engages 54,000 stakeholders across 170 countries. Thank you very much for your attention. Before we move to the panel discussions, I have to note that unfortunately, due to the cancellation of the flight, Professor Marlene Osterman and Mariah McKimbrough would not be able to be with us today. And before requesting Katherine to start the panel discussions, I would like to invite our new partner organization working on the migration policies, Olga. She will explain, this is the brief that the Global Migration Policy Associates developed on sepsis and the migration risks, so she can introduce briefly their work, as this would be the only opportunity for her intervention, please.
Thank you very much. Should I come up? Dear colleagues, it's an honor being here with you today to share with you on this very important topic, and I'm very grateful to Mariam for the invitation. And a few words I would like to share addressing specifically concerns for migrant and refugee populations and the risk that migrants and refugees face in this realm, built on the address that Patrick Taran, GMP President, presented at the World Health Assembly side event in May this year, and the brief that all of you have on your chairs as a take-away, take-home paper has been developed and updated with new data and figures. So first of all, why migrants and refugees? So UN data, UN statistics tells us that there are 304 million persons in 2004, or 3.5% of global population, that are migrants. But that data takes into account only those who have been, who are foreign-born, who have been resident for more than a year. So in reality, migrant population is significantly more, because if we take into account all those in short-term seasonal work, all those migrant workers who come and go but don't change their country of residence, and so on. So the number is very significant. But as we all know, migrants and refugees are very often left behind and lack health care and lack access to health care and protection and so on. So just to highlight that what needs to be done, a sepsis agenda addressing migrants and refugees. It comprises targeted outreach and interventions that need to include, first of all, health education for all, with outreach to immigrant communities, and of course including a mention of specific sepsis risks, prevention and responses. Then, of course, providing sepsis and related knowledge regarding immigrant, migrant, refugee, foreign populations, and training health professionals at all levels, as well as in research. Then, of course, information in languages that migrants and refugees can understand. Then, of course, enhancing proximity of primary healthcare services, focusing on occupational health, occupational safety and health risks, and a number of other important points. So all of them are in the brief that all of you have. Thank you very much once again for the opportunity to highlight the concerns for this specific population, and of course to mention that this agenda coincides with the 5 main strategic pillars of 2030 Global Agenda for Sepsis. Thank you very much for your attention.
Thank you. Thank you very much. Indeed, migrant and refugee risks and determinants require special attention in the sepsis response. And thank you for joining us. Thank you for preparing this policy brief that has been already distributed to our participants. Now it's my great honor to invite my dear friend and colleague, Katherine Urbáez, who is the CEO of the Health Diplomacy Alliance based in Geneva. And from our first meetings in Jeddah around AMR Ministerial, we have really discussed how we could join forces in the fight. Please, Katherine.
Thank you very much. Mariam, it's really an honor for me to start this panel and to welcome you to the discussion. We're gonna try to unpack what Mariam just said about the 5 facts. So for that, we're going to be 5 of us trying to discuss about some of the facts that you mentioned and how we can bring this sepsis into the agenda. It is an honor for the Health Diplomacy Alliance to join this panel, not only because of the high burden of disease that you mentioned that sepsis brings, but we understand that it's part of our cross-cutting agenda of the work of the Alliance, and also because of the political traction and the need to raise not only awareness, but also the funding that is required to this agenda. So I will be accompanied by a group of experts who will try to unpack some of the questions that I'm gonna pose in terms of those facts that you mentioned. And I will call them to join me on stage. So the first is Dr. Terry Reynolds, which is Unit Head of the Department of Performance and Financing and Delivery from the WHO headquarters here in Geneva. Pleasure. Then we have Dr. Ben, who is the Director of Joe Langen Institute Global Health and Diplomacy. It's a pleasure, Ben. Dr. Leite from the Swiss Sepsis Program to join me. And Josué Laus, Youth Advocate. Welcome. Thank you for joining the panel, and I will pose some questions to see how provocative we can be in terms yeah. So you've been working a lot in terms of the development and coordination of the guidelines of WHO in terms of clinical management of sepsis. In your view, what are the latest initiatives that are happening within WHOs in terms of response to policies and instruments and at the community level? What is the work that right now WHO is having in that sense? You have the microphone here.
Thanks very much. So it's a good question. I mean, it's not an easy one to answer quickly, but given time, let me sort of answer it categorically, perhaps. You've heard from the Director General a range of things that we work on. You've also heard a lot of really big numbers, and many of them, and it's very hard to process those numbers. So WHO does a lot of different things, but one of them is we just try to keep in the forefront of people's minds what this means in countries around the world. So 11 million is a big number, 3 is a very, very small number. And so you count out 1, 2, 3, and another person has died. And that goes on all day, every day, all night. So one of the things we do is try to return awareness of what can be a global advocacy campaign to the reality that countries and people are dealing with, countries and communities. Then that said, we work on a number of operational levels, so it can be helpful to think of this in terms of policy. You don't want brand new policies on sepsis alone as such. They're extremely powerful policy levers into which you need sepsis to be integrated. So integration is a very key thing for WHO. That's a very abstract term, but it's very simple what we mean by that. 2 of your most powerful policy levers in the world right now are national health strategic plans and universal health coverage. So what that means, universal health coverage is associated with a package. Every country undertakes either a robust or a less robust process to identify what are its priority services. What you want is the services for sepsis in that package, because everything else follows, the financing, the planning, etc. What WHO does about that is we have a universal health coverage planning platform that we have recently gotten a package of sepsis services in. So it empowers countries to much more fluently, much more effectively say, what do I need to happen where? And you heard from Elia's story, you heard from other stories, there were a number of things that needed to happen at each level that went wrong. And so empowering countries to make the right choices for each platform in their health system, that is a big part of what education does. Education is a huge part. We have a number of courses, basic emergency care, basic critical care, dedicated modules on sepsis to gain capacity in health workers to recognize when someone, a child or someone else, is in front of them. And then finally, process tools. We do a lot of work on process tools because very simple changes can be made that do not, and no one understands or believe, not no one, but people frequently don't believe this, but there are a number of simple process changes that can be made with no new input of material research. So, and those have to do with processes for triage, processes for early recognition, patient flow processes, but those are infinitely scalable because those changes can be made. So we spend a lot of time trying to create tools that allow facilities, not even just countries, facilities, districts, subnational units to make these simple changes.
That's super interesting. I will revert back to you to see how member states are working on this and how WHO is cooperating. But I will, before that, I will take the profit of the experience of Dr. Ben. As he was mentioned, you have been really involved in a lot of health financing innovations in low middle income countries, from the co-creation of the global public investment concept and also some other work within WHO, CEPI. How we go away from this paradox of sepsis. And we understand, we have seen the numbers, but we know that it still is not visible enough and is underfunded. So I want to ask you that question. How, on your leadership, you were able to, with the Global Fund, mobilize around 50 billion pledge. Can we do that for sepsis?
I would love to. Thank you, Katherine. And before I kind of try to answer your really challenging question, I want to express as well, Mariam, so much my support for the work that you have been doing, with the Global Sepsis Alliance. It's so essential, so important, and I'm fully behind. And I want to say also to you how much your statement has touched me. And I know from my own experience that you alluded to, appealing to politicians, to decision makers, to funders, to fight and fund the fight against AIDS, tuberculosis, malaria. Nothing has been more important than the personal testimony. When it comes to political decision makers, nothing convinces them more than personal testimony. Not the facts, as important as they are, not the experts, as important as they are. So thank you for that, and it has encouraged me because I know that's a very, very important step on the way to develop a really kind of effective campaign. Political support. So then briefly to your question, because I don't want to spend too much time on this first question. If you're asking yourself what is required to really mobilize political and financial, there are many factors, but two stand out. One is you need to be able to demonstrate that there is strong evidence for the size and the urgency of the problem. That is no issue. We've heard all the kind of facts. It's huge. It's completely underappreciated, underestimated. So no question about the urgency. But the second factor is a much bigger challenge for the global fight against sepsis. That is, politicians respond mostly if you can present them with a fairly simple solution to a complex problem. You have to break it down to something that they can associate with it. They say, okay, if I support that, if I invest in that, what can you achieve in the next year, or the next 3 years, next 5 years? Don't tell them about 10 to 20 years. Don't tell them about very complex processes. That's where you have a much bigger challenge. It's not to say that it should not be done. I really agree with you. Every death from sepsis is a tragedy, and one death too many. And preventable deaths are then the responsibility and the justice. But for politicians, they don't respond to these appeals. They want to know, okay, what are you telling me what I should fund? Tell me what the outcome will be next year, and how cost effective. And that's where we have this challenge, because issues that you presented, like protocols, like national plans, like hospital hygiene and so on, all very important, very, very necessary, but not so easy to translate. So I think the challenge for the next phase will be to have two key elements. The urgency and the size of the problem is there, but how to translate that into communicable interventions that seem to be also affordable. You mentioned, that you have the huge burden in low and middle income countries, much more needs to be done there, and they want to understand, okay, if we really put it high on the agenda, we provide funds. So, not impossible, I think can be done. I'll probably come back to that, but that needs to go into this kind of investment case that can then really convince decision makers.
Very much. I will also come back to you in sake of time for follow-up questions. But we have heard during the presentation that the big burden is in low, middle income countries, but we have seen how that been increasing in high income countries. And for that, I want to ask Dr. Leite, you are in charge of the Switzerland National Action Plan for Sepsis, and you are quite aware of how it works in terms of intensive care medicine, and you are in epidemiology. So, I mean, like the case we have seen with the family of Elia, how does Switzerland, in terms of their national the national action plan, what factors have facilitated Switzerland in terms of putting in practice this program at the national level?
Thank you very much for having me here today. I'm very honored to represent the sepsis program today. Yes, as you mentioned, being a high-income country doesn't automatically mean that you have a coordinated action. And in fact, before 2022, Switzerland had no national standards, no coordinated strategy, and also no quality improvement program for sepsis. And we have seen the numbers. Yes, low and middle income countries are most affected, but the global burden of disease study estimated about 20,000 cases in Switzerland and more than 3,500 deaths annually. So just recently we published our national epidemiological data, and they confirmed the magnitude of the problem. So it's being a consistent and deadly disease also in Switzerland. And this evidence, but also experience from other countries, were the foundation to our national action plan. And it was developed in 2022 by a multidisciplinary panel of clinicians, researchers, public health experts, but also sepsis survivors. And it was supported and endorsed by many medical societies. And the plan really provided a strategy and the political visibility we needed. Because what made implementation possible was timing and also opportunity. Because a newly founded and established Federal Quality Commission had the capacity to fund national quality improvement programs. And they committed 10 million Swiss francs over 5 years, making the Swiss Sepsis Program our first nationwide strategic initiative on sepsis. And the program is led by 3 university hospitals in Zurich, Bern, and Lausanne, and is structured into multiple work packages. So we will promote public awareness and advocacy, an educational program for healthcare professionals, and also clinical standards and pathways. But together, we will also make some benchmarking and evaluation. So from the very beginning, it was designed to be multilingual, because that's a reality here in Switzerland, multidisciplinary, transdisciplinary initiative. So we had a clear plan, we had broad alliances, and we had new funding mechanisms, and they all came together at the right moment to move us from our vision to action.
Thank you. I will also come back to you and follow up on the success of Switzerland and also the challenges that is still out there. But I want to turn up to you, Jose Laos. You are a youth representative. You are master's students at the Graduate Institute, and you are passionate about global health diplomacy, and you already have some experience in UNAIDS and in the permanent mission to the UN of Peru. So how can youth be engaged into raising awareness of sepsis to the general public, to the policymakers, how we can use the media now in the trends that we have all the influencers, how we can make that message to reach everybody? Over to you.
Well, good afternoon to everyone. It's such a pleasure to be here. Thanks for the Global Sepsis Alliance, and to be just with these actors, it's amazing. I'm actually now a little nervous because it's with you guys. But what does youth engagement mean in global health for me? Well, it's more than just a representation, but it's about taking action. We know that our youth is innovative, is creative, and they're more connected than ever before. We cross messages, we text even when we're very far away, and that's one of the tools that we see in the youth now. So what does that mean for sepsis? For sepsis, that means that digital platforms are one of the methods that we should use to spread awareness to others. Because again, this is how we communicate nowadays. And this is something that we're learning here in global health more and more, but now this is our reality. As I said, if the youth represents the future. So if we start investing in the future, we will have better outcomes. My second point is also that putting them in the health agenda. We've seen that HIV has been in the health agenda before. We've seen also climate change. We've seen also the humanity aspect, the equity aspect, but we haven't seen much of sepsis. And this is something that we have to raise awareness. And lastly, I have the youth leadership perspective as well, because as well campaigns and events like this, we need them to spread the voiceless. They are the ones who are more connected than most of us are. I mean, TikTok, Instagram, Facebook, influencers, they move masses of people. So this is one, three ways we can spread more awareness.
I come back to just to touch upon what you mentioned in terms of policy implementation, but how WHO is working with at the country level to support countries, especially in low middle income countries, to really support in the inclusion, as you said, in the inclusion of national programs, but also to really effective implement guidelines and improve within the clinical work for sepsis.
Sure, so the two questions are kind of a mirror of each other, right? Kind of what resources does WHO have, and then what do we call on countries and other stakeholders. So I'll try not to repeat too much. One thing I would say is we do have a website, so that if you search, say, clinical care of sepsis and then who.int, you'll get kind of a lot of these specific things that may be of value to you in your work. So in case I leave anything out, let me point to the website. I think, so he's right that the trick is to make this message simple. It's also the one thing I would add, I agree with everything you said. It is also helpful, you have to remember that when you come in to see a minister at 10 a.m., the minister has had 5 other people before you and 25 other people after you, and it can be helpful to bring a solution and not a problem. So one of the powerful opportunities that we have with sepsis is to talk about certain things that the minister has already committed to and say this will, by investing in this, whether that is pre-hospital care or early recognition or an emergency care pathway, you will also get the following benefits for your maternal health problem. So exactly the same system changes that reduce mortality from sepsis are the same ones that saves lives from postpartum hemorrhage. So this sounds obvious, but this needs to be said sometimes, depending on who your audience is. And then if you're talking to and can tolerate the slightly more wonky framing, and you're right, it can be very off-putting, but in the end, what we're talking about is policies that are operationalized through models of care. And whether those abstract terms are implicit in your head or explicit, depending on your audience, we need that framework. And so models of care break down very simply, and this is what we work with countries on, into packages, platforms, and pathways. And so depending on whether the person in front of you has already said, I want help working on sepsis, if that's the case, great, the conversation starts a little bit further along. If they haven't, you say, look, you're really interested in reorienting your model of care towards a PHC approach, because almost every minister is saying that right now. So you say, look, I work on sepsis. What we need is at every level of the model of care, at the level of the package, the platform, and the pathway, we need to make sure the system can meet the needs of people with sepsis. That will give you this many lives saved. Because in many cases, he's right that a powerful investment case works very well, but in many cases, these investments are already being made for other reasons. So you can have a shared investment case for the input, but get an additive output of all of these lives saved, because they're not fully overlapping. They're a little bit overlapping, but not entirely. So your child health plan should be built around sepsis. Your maternal health plan is obviously also has to accommodate sepsis, et cetera, et cetera. And so very concretely, we have a resolution on emergency critical and operative care integration, right? That is a big advocacy opportunity that anyone can use. We also, this assembly will have a global strategy that comes out for that breaks it down into slightly more operational categories. And then finally, a global action plan will follow that. Mm-hmm. And that is where you see specific things that countries can do. To go back for a minute to the packages, platforms, pathways, the packages, it's very simple. You want in your UHC package, you want the services needed to address sepsis appropriately at every level of the system, from the community to the clinic to the hospital. And that's just a phrase. You have to keep saying again and again. Every country in the world is committed to some strategy for UHC. Not all of them have committed to sepsis.
So that's your packages line. Then with the platforms, you want functional definitions of platforms. In this country, what do we want the community health platform to do? In this country, what do we want a clinic to be able to do? What do we want a hospital to be able to do? And in each of those cases, you ask yourself, or you make the policymaker or the subnational planner ask, okay, if this is how I'm defining the function of a community health center or a hospital, will that serve the needs of people with sepsis? Have those decisions, have those definitions occurred in such a way that so you're not asking them to do a new plan for sepsis. You're asking them to test the decisions they're making at the level of packages, platforms, and pathways as to whether they will meet the needs of a specific individual with sepsis, of a community where sepsis is prevalent. And then finally, the pathway one is very straightforward. It sort of builds on the others. Once you have a package that assigns priority services to platforms, then you need to just think about the linkers. How do you link communities to the health system? And how do you link the platforms to each other with referral, counter-referral, early recognition protocols? So that is a very wonky answer. It's not your simple people to care and care to people. You can do those too, but at a certain point, if you're asking, my experience with even very high-level policymakers in the most challenging situations has been that they're incredibly intelligent and they want technical operational solutions. Their brain is very, very full with agendas, the people that came before you and the people coming after. So you need to be able to quickly say very practically, what can that person from where they are sitting do? And how does that link to things they've already committed to, whether that is UHC or saving mothers' lives or saving children's lives? You say, look, here's how many of your kids who die are dying from sepsis. Fix this. People are not exactly dying of HIV, they're dying of sepsis. Fix that, so et cetera, et cetera.
Yeah, so it's looking at what is scalable. We're ready with policies that are in place or national programs that are in place, and look at the three-step, the package, the platform, and the pathway, and not inventing for the moment something new, so we can integrate it in the national plans.
Yeah, I would say with the exception of the pathway, I think it's very powerful because we've worked a lot. You do need a dedicated sepsis pathway, and we've worked a lot with that. And then in the right situation, a national sepsis plan can be a good way of making elements of your policy, your packages, platforms, and pathway explicit into one document so that you can focus for a minute. And we do see, it's very powerful what you just described, because we see it a lot, but it rarely comes from the mouths of the high-income countries involved. So as WHO, we see it very frequently, these countries with a lot of money who have an excess of services and an absence of system. And so it's hard to convince people, and they're very, very wealthy countries like this, and it only manifests with acute conditions. You can by things that move slowly, you can more or less buy your way out of the problem. Things that move quickly, you can't buy your way out of the problem. You can have, Switzerland lacks absolutely nothing to deliver perfect sepsis care. The only additional thing that could be needed is the system to connect the services that are available. And I don't single out Switzerland, but it's true in many settings. And that, again, that is a true tragedy because it doesn't require, again, any new input. It requires better use of what we have. So,
in terms of financing, so are we talking at the national level for budget allocation? Are we talking about the possibility of putting already, as I said, within our national plan or our universal healthcare kind of program? Do you think this should come from national budget, or are we able to integrate donors and philanthropic organizations to be attentive to what is happening and how to integrate that into fundings that are coming into a national and regional level?
Thanks, Katherine. When I was sitting there listening to Mariam's facts and figures, I was thinking back of the years 2000, 2001, when I was involved in the advocacy for setting up the Global Fund to fight AIDS, tuberculosis, malaria. At that time, it was estimated that 6 million people were dying from these three diseases. So that's just about half of what we learned today, the number of people dying from sepsis. And yet, that led to a situation, fortunate in this case for what I was advocating for, that Then Secretary General Kofi Annan said, 6 million people are dying from these 3 diseases. That's completely unacceptable for the global community. We need to do something dramatically about it, not something piecemeal, dramatically. Called for a UNGA special session. All member states agreed, let's create a global fund to address that. 6 months later, the global fund was operational here in Geneva. So just to mention, that's how it worked at that time with those numbers. Now, we are not in the year 2000, we are in the year 2025. Completely different situation, politically, financially, fiscally. So nobody would now even try to argue for a special fund for sepsis control and so on. Politically, there wouldn't be support for that. Therefore, very clearly, the answer to the challenges we've been discussing here today is integration. I think just as you said, sepsis is part of, the response to sepsis is part of creating strong health systems, investing in health systems, and is very much part of universal health coverage. The agreed goal of the SDGs, SDG 3, and so on, that not only WHO, but many have been advocating for. So that's where it's sitting, if you like, right, within that framework, and needs this kind of integration. But that is also then the opportunity. Yes, and then you need this to be integrated into national plans, very important. But, of course, there is also international funding for health systems. There is international funding for universal health coverage. You're asking in the written question that I got, is it possible to integrate that partly, at least, into Global Fund, Gavi? They have health system strengthening windows, right? Global Fund now invests $1 billion per year in health system strengthening. Can this be integrated? I would argue it can, but it doesn't come from Geneva. It comes from the countries that are making the plans on health systems. Nobody tells them you should invest this and that and the other. No, the countries make the plans, and they need to integrate sepsis into that. So that's where it will be sitting, and then you can attract, the interest of international donors, be it public, be it private, and philanthropy, and so on. And I think what we should consider is how much we can turn that into win-win, into a kind of mutual benefit, right? Because let's face it, everybody arguing for health system strengthening investments and universal health coverage is pretty vague as well, right? It's not high. Here are the kind of 2-3 key interventions, just fund that and we will be in a wonderful shape, right? No, not at all. Almost sepsis is a little bit more concrete than some of that. And as you rightly said, sepsis is the human face of antimicrobial resistance, for example. You could also say it's a very sensitive indicator and a face of, strengthen health systems towards universal health coverage. So you have to turn that into win-win so that indeed sepsis, with those numbers, with the human stories behind that, it is a driver also towards additional investments in health systems and UHC, right? Not as a separate program, but as part of that, but as a kind of also way how to communicate why it is so important to strengthen these health systems. It's not for some vague idea that somebody thinks in Geneva and writes a concept note. No, it is affecting the lives of people, and with sepsis you can demonstrate that. So that's my answer. It's all about integration, not a kind of separate funding stream would not be. But there are, of course, funding streams. Gavi Global Fund, but World Bank and many others have, funding streams on health systems. That's where it needs to get into, and it needs to originate from the national plans, but then go to the boards of those international organizations and the philanthropies and so on, and by telling the story. I mean, that's what you're doing, right? And that's what we're here for. But it starts, whether you like it or not, it starts with telling the story. And then you might get the attention that can change things around.
The awareness part and the understanding. I mean, as you mentioned, politicians are quite aware of what happened, but you have to demonstrate that there is a face to it, and also that there is a solution to present, and how that it is important within their political agenda as well. This is something also important to have in consideration. I go back to Switzerland. So what do you think are still the remaining challenges of implementing the Swiss national plan and programs, and how you see as the main priorities in the coming years?
I already mentioned it. We have a very decentralized federalistic system in Switzerland, and also multilingual system. So it makes it a bit more challenging to really communicate effectively in at least 3 languages simultaneously. So we have to make sure that our messages are simple and understandable and work in all languages. So that's one of the main challenges. But then the other one is also that we have no legal mandate for hospitals to adopt our standards or pathways. So the coordination and uptake will be ongoing challenges, but also long-term sustainability. So we have a 5-year funding, and we have to make sure that the program continues to run beyond our horizon. So then another major challenge and gap that we're still facing is that we don't have a national registry yet. So we have no integrated clinical data, and without this kind of data, it makes it very difficult to also for the hospitals to support their quality improvement progress and to measure our impact. And this is also our next priority. So we will try to build a national registry and also strengthen the benchmarking across hospitals so that they can really compare each other, compare their performance transparently, but also to report back to policymakers, of course, because as we heard, it's very important for them to understand the impact, but also the numbers who stand behind it. And then we will, of course, we're still developing and implement and testing our pathways across different hospital types as well. So smaller hospitals, larger hospitals, and again, in all linguistic regions, in pediatric and in adult hospitals as well. And then we will implement also not acute care pathways, but also post-sepsis pathways. And we're working together with the Swiss Society for Intensive Care, for example, but they have a lot of experience, and of course with survivors there. So the challenge will be sustainability, it will be data, having good educational programs that will also be accepted by our medical faculties, universities, but we also have some strengths because we are a small country, so that makes it sometimes a bit easier to have direct connections with all the major stakeholders.
Back to you. We are talking about how youth can bring their voice. And how do you see youth involved in those big decisions that our politicians are taking at the national level, and how youth can be used also to translate the message of survivors, of families, into the discussion and to be part of the discussions within sepsis agenda?
Yes, so youth are conductors of information. And we've seen numbers, we have demonstrated data of sepsis and their survivors, but it's different when there's someone coming to the room and telling you the story. I think this is very powerful, a very powerful message. And we're always bombarded with so much information nowadays that if we just see data, we probably don't even pay enough attention to it. And so bringing people, faces to numbers that we're seeing here, it's much more relevant. The next one I will think it's the peer-to-peer advocacy, because we've seen that, for example, I know that everybody here has knowledge in what sepsis is, but if I talk to my friend, potentially they might not know what sepsis is. So we need to start also by sharing this information, me included as well, because the youth is, again, the conductor of information. And when it comes to the government aspect and bridging these gaps, the youth are the answer for this. I think there are so many ways how we can translate this information into their own language. We speak another language than your generation speaks. So this is very important as well, to bring the advocacy aspect of it. Thank you.
We all are, young in spirit and in age.
I'm feeling pretty old.
Yeah.
I'll take that.
So I will say, I mean, there's so many things that, I have one. There are so many things that we have discussed here, so many facts, so many aspects that seems to be really easy to digest in only 40 minutes, but it's a complex process. So if you have to summarize with one action, one recommendation, so we can move that agenda forward, what would that be? Choose one. Recommendation, action, choose one.
Talk about the integration to the existing funders. You're obviously talking very well to WHO, very, very important. Normative guidance, standard setting, you have Dr. Tedros as your key advocate and the teams there. But you need then also the existing funding organizations. I look at Linda over there, GARD-P, for example, right? Funding AMR, right? And we heard, hey, there's a close link between sepsis and AMR, Global Fund, World Bank. So that's maybe the important step for the funding part. And again, it's not so much the people at the central secretariats, but more from the countries so that it filters up, the demand for that. That would be my.
It's a bit similar, but it's find friends and learn lessons, I would say. So Mariam can talk as well as I can about this, but WHO hosts the Acute Care Action Network that is mentioned. If you know what you want to happen to save lives from sepsis, sometimes it will happen for sepsis, sometimes it will happen for something else, but what you care about is getting your actions executed. So make friends who want the same thing, because it's great when you're not the only one doing the work towards your goal. So that's one thing. And acute care is a sort of powerful way of starting that, at least, because one thing that comes to mind listening to this group is there's probably an enormous amount to learn from the road safety advocacy, because it went through a very similar natural history of evolution, with similar numbers as well, and with a very powerful youth force in particular. So anyway, it's really about that. Make friends with people who want the same things, that you'd be very clear about what you want to happen, and then make friends with people who want the same things to happen, whether or not they're telling the same story.
Yes, I would say from our perspective, international collaboration was really pivotal. So we learned a lot from Germany, and we still are learning a lot from German experiences, but also pitfalls or challenges. So we discussed strategies together. I think that really helped us to not repeat the same mistakes. Then also from our friends from Australia, where they shared a lot of insights in how to formulate such a plan, how to implement the plan. So I would say don't reinvent the wheel, learn from each other, and build on what's already been established here.
And lastly, I would say, based on the information as well, every 3 seconds, a person with sepsis passes. So I think that's a very strong information, very shocking as well. And personally, coming from South America, I've seen how the health system is very fragile, it's very weak. And the youth are seeing this, and our generation is seeing this. And this is why a youth-led involvement when it comes to sepsis is very key. And not just by speaking and advocacy, yes, but also in the political spheres and also in the health spheres. And this is why we have to incorporate them in the agenda. And that will be my take.
I will say we had touched upon the importance of awareness, the importance of national policy implementation, of using what already exists and be able to translate and scale it. We are talking about integration, making friends of those who are doing something similar, cross-cutting areas. We are talking about international cooperation and the power of message of youth. And that means that sepsis is something that is not different for low, middle-income countries. For high-income countries is something urgent that we have to see, and something that we have to also have in consideration when this is in an emergency situation, or when we talk about war and conflict, which is something that is also another aspect that has to be in consideration. How to integrate it at the national budgets, how to integrate it in already existing funding, and also how to translate the policy into the reality of the voice of the families and the survivors. So thank you very much. I want to thank my panelists for all the discussions, and I think this is a start of other further discussions of the importance of having sepsis in the agenda. Thank you.
Requests for interventions that I would love to respect and call from our partners. But you gave us a very interesting guidance in terms of our next homework. Because solving the paradox of sepsis exactly as the former minister parliamentarian, the UN person who led UNAIDS and Gavi and Global Fund application increase, we can see the avenues where we could really, in a smart and very easy to digest way, integrate sepsis advocacy agenda. And when we complete our homework, we'll come back to you for your possible additional advice, because I see this visible. The message is so clear, the burden is so high, like the responsibility is so high in terms of non-responsiveness that we will find a way, we'll find a solution, and your recommendations are extremely important. Thank you so much. Please stay in the panel seats, and we will call for the two last interventions and close the meeting. One is from our partner organization and our biggest supporter of the World Sepsis Day movement, from Massimo's representative, Stacey, your seats, and me. Yes. Oh, yeah.
Yes, thank you, Mariam. Konrad, thank you to Elia's parents. At Massimo, we've been focused on patient safety for our entire time of being a medical device company, but as a medical device company, we're formed of parents, of students, of people growing up in their lives who expect to survive a very long time. And we come to the table to be part of the partnership in what you've shared today, that there are faces behind all the numbers, and that working together, it should be less expensive. It should be better to survive by preventing health challenges, not by reacting to them late. So you talked about moms, talked about kids and the World Health Organization Patient Safety Agenda for Children this year and neonates. Acting faster, acting sooner, and being okay to act when it's not a crisis, but spend early to make change so that faces are the faces of everyone having fun in life is really important. And we're very, very focused on the fact that quality measurements of people need to be possible when someone is not tied to an ECMO machine and not tied to a wall, but moving about their everyday life like we do with things we wear now and apps we carry now. It must be easier for us as citizens to respond to health data earlier. But immense thanks to all of you for making a face to something that should be a never event, that we should believe that having good health is possible and that intervention early is possible and surviving is possible, not just from things we catch from other people, but health things we can make to intervene early and to stop the progression. So thank you very much for everything you do so we can believe and support you all.
Thank you, Stacey. Every partner support is extremely important, because we just need to wait until we can make that breakthrough in terms of understanding and, like, as I say, like snowball effect of kind of reaching the minds and hearts of policymakers and decision makers. And we have another intervention from our new kind of stakeholders, so please.
Great to be. Today, Robina Namulindwa, I lead Kiripasa, France and Switzerland, on what I called End Maternal Mortality Program, which works in Africa. We started with Uganda, Kenya, Tanzania, but we are targeting all African countries with an aim of ending maternal sepsis. I'm glad to be here. I have a team in Uganda and in other countries trying to be on the ground and fight this. Women, I'll talk about the pilot study I had in Bugiri district, Eastern Uganda. I wanted to know what are some of the factors that hinder these women from accessing care. They explained the distance they take, or what hinders them from, having proper antenatal services. So Kiripasa, Switzerland and France takes antenatal clinics closer to these women to bridge the gap. I've done this and I've seen low rates of maternal sepsis in African countries. I'm glad to be part of you as we fight maternal sepsis. Mm-hmm. Thank you.
Thank you. Thank you so much. Thank you very much. And as already mentioned, I think that with today's meeting as part of the global World Sepsis Day movement, we have definitely brought in new friends and partners to our fight, to our common cause. And we're extremely grateful to each of you who managed to join us in person, and to the hundreds and I believe over 1,000 of participants who will be viewing this meeting online. Of course, our fight continues, our campaign continues, and those of you who will be joining the UN General Assembly this year, you're kindly invited on September 24th to this special side event on sepsis and NCDs that, again, Global Sepsis Alliance will be convening in partnership with Medical Women's International Association and our strategic partners. Let me close this meeting again with the expression of gratitude to each of you, and especially to Jennifer and Danielle for being with us and for helping us to reach others with the pain that you have gone through. And I hope that every year we will be stronger in terms of our kind of joint voice and joint action. And we hope to be able to truly prevent millions of deaths if we are able to implement the 2030 global agenda for sepsis. The estimates are that every year we can prevent 12 million new sepsis cases and save at least 2 million lives. I think this is the cause that is worth of every single effort and every single attempt to help each other. Thank you very much.